Welcome to this show discussing problems and issues of health with Dr. Alcena. For this segment of the show, I'm going to continue to talk about acute pancreatitis. Last week I spoke extensively about acute pancreatitis resulting from alcohol abuse. This segment I'm going to talk about acute pancreatitis resulting from gallstone. 80% of acute pancreatitis is the result of alcohol abuse, 20% the result of gallstone. Now, I'm going to take my time and give you a little bit of background on the basic anatomy and physiology of the pancreas so you can understand best when I explain to you how it becomes sick because of the gallstone. Right here is the pancreas, right here. You see this series of ducts. The pancreas has two main ducts. First of all, it has two main functions. One is the endocrine function, one is the exocrine function. The endocrine function deals with the production of three separate hormones, okay? Three separate hormones. And let me name these hormones for you. One, of course, is insulin, which is produced by the beta cells and at the part of the pancreas called the island of Langerhans. And the second hormone is caused by the alpha cells, which produce glucagon. Glucagon causes sugar to go up. Insulin causes sugar to go down. Okay? And you have the delta cell, which secretes another hormone called somatostatin, which regulates stop alpha and beta cell. All right, so those are the three endocrine cells that the pancreas produces that we need in order to remain healthy. Roughly, an adult human, according to the literature, has about 1 million beta cells, about 1 million. And then once you lose those cells, you can't make them back. The pancreas cannot make them back. You were born with them. And that's what happened. As you lose the beta cells, then all sorts of problem happens, mainly diabetes mellitus. Okay, now, so that's the basic structure of the exocrine function, of the endocrine function of the pancreas. Now, the pancreas has another function called the exocrine function. The exocrine function is what I'm going to concentrate on mainly in this segment. Namely, the pancreas produces a series of enzymes, which is basically juices, if you will. And the pancreas has two main ducts, the main pancreatic duct and the accessory pancreatic duct. Through these two ducts, the pancreas, the juices that are produced in the pancreas are able to go from the pancreas into the what's called the ampulla of Vater into the duodenum of the stomach. Okay? The ducts, the pancreas produces these juices, we call them enzyme. What are the function of the enzyme? Well, we need the enzyme in order for us to digest our food, be it carbohydrate, fat, or whatever food that we eat. The pancreas is involved in producing the enzymes that are necessary for us to digest this food, otherwise we cannot digest the food. Okay, we get very sick, we can't digest the food. Okay, however, when the pancreas secretes those enzymes, it has to go through those two main ducts into the ampulla of Vater, dumping the juice inside the duodenum of the stomach for us to digest our food. Okay, so now you have a basic idea of the anatomy of the pancreas, why it is such an important organ. Now, what happens is that when someone this is the gallbladder right here. Okay, this is the gallbladder. Once the bowels and the gallbladder become precipitated, okay, it produces stone. And the stone, I would say roughly 70% or so of the stones are cholesterol stone. Then you have mixed stone. Then you have stone that come from breakdown product of hemolysis. So the stones get stuck here. Once the stone gets stuck here, it blocks the main pancreatic duct. So the enzyme that the pancreas is producing cannot go through. they back up into the pancreas, causing an inflammation to occur, resulting in acute pancreatitis. That's the mechanism. A whole host of other stuff can happen that can cause somebody to have pancreatitis, but I'm specifically staying with gallstone. And I spoke a couple of shows ago about the different percentages of individuals who have gallstone. I'm not going to go through that again. Suffice it to say, either the stone, a big stone, or a little gravel, block up the flow of this enzyme that the pancreas produces, and they're backed up into the pancreas because they stay there in the pancreas. They're not supposed to stay there. The pancreas is supposed to secrete them and it's supposed to be carried away. That causes a local inflammation. The pancreas becomes severely swollen, and then the person then start having symptoms. Now, I'll give you a list of the symptoms, okay? The symptoms are many, okay? I'll list some of them for you. Nausea, vomiting, loss of appetite, fever, chills, tachycardia because of the fever, that this is fast heart rate, and abdominal pain, especially in the right upper part of the abdomen where the pancreas, where the gallbladder is located. Then, of course, the person can have also go to have peritonitis. Hiccup is another common symptom as well. And the person can become hemodynamically unstable by basically collapse and dropping the blood pressure, and somebody can die. So it's a very serious condition. I just given you the symptoms. So the person will present to the physician with these symptoms. Okay, you listen to the patient carefully. You see, you have to remember, more than 75% of all diagnoses are being told to you by the patient. If you know how to listen and listen carefully, don't interrupt the patient, just listen to what he or she is telling you, and you're likely to arrive at the diagnosis right there while the patient is talking. Not always so, but most of the time. Even if you don't arrive at the diagnosis, if you listen carefully, you will take a path based on the history that will lead you to make the diagnosis pretty quickly without wasting too much time and money. But that goes with, of course, experience. Okay, that cannot be taught. You just have to develop it over the years. I've been at this for 42 years nonstop. So, and it become like second nature to me, literally. So, now that you take the history, you're going to examine the patient. What are you looking for? Well, from the skin, you're looking to see if the skin is jaundiced, because if this stone is blocking the tubes, it's also likely to cause the bowel to back up as well. So you look for jaundice on the patient's skin. Is the patient jaundiced? Looking at the patient's sclera, the white of the eye, is the sclera jaundiced? How jaundiced is jaundice? We have ways of sort of grading the intensity of the jaundice by looking at the sclera. Okay, so that's, you start there, and then you listen to the lungs, listen to the heart, then comes to the abdomen, the specific technical way of examining a patient's abdomen. And I'm not going to detail that to you. That's not what this is all about. I teach students how to do it. I've been teaching the students for more than 40 years now how to do it. Okay, so once you get to the right upper quadrant of the abdomen, you got to be very careful not to press too hard, and then you look for the gallbladder is located, and it's likely that area is likely to be tender, and it also have to be, when you let go, the patient feels it. That's called rebound tenderness. And then, of course, you're going to listen to the abdomen as well to make sure that the patient doesn't have peritonitis, meaning that we know that the gallbladder is inflamed. It's likely to be infected as well. So we need to know physically what are we dealing with in terms of the intensity of the problem. So if the patient have rebound tenderness and the bowel sounds are absent, that's an indication that the patient probably has peritonitis. Something happened so drastically that the pancreas become infected, and now you have your hands full with a very serious medical surgical issue. Okay, so now you finish with your examination. You're going to proceed now to do some blood tests. Well, you want to check the patient's blood count. What are you looking for in the blood count in someone who has acute pancreatitis that may be due to gallstone? Well, you look at, is the white count elevated? Yes or no? That's very important. Both inflammation and or plus the infection can cause the white count to become elevated. Then you're going to look at the differential count, which is something that we smear the blood and we stain it, and we'll look at to see the percentage of certain cells. We call them segmented polys. If the segmented poly level is very high, we say this is a shift to the right, meaning that, see, when you go to the bone marrow, the bone marrow produces these cells. We as human, when we were born, we get to be very small and we grow bigger as life goes on. Well, that's not necessarily what happened. In the bone marrow world, the younger the cell, the bigger it is. Okay? So it's the reverse. So therefore then, the patient's differential count is likely to show the patient to have a shift to the right, meaning the segmented polys are now more, that we are seeing are more mature, but also there in the blood profile, you're likely to have very large white blood cell called band. That means there's a shift to the left. A shift to the left, let me explain to you what a shift to the left means. A shift to the left is that as we mind our own business every day, inside the wall of the large vessels are lined up with white blood cells. It's very important that I explain this to you so that you understand this stuff completely as much as possible. As we sit here, our large blood vessels are lined up on the inside with white blood cell. Plus we have white blood cell in the circulation. The white blood cells that are lining on the wall of the blood vessel are waiting to be called upon when there is an infectious situation that's attacking the body. Then the body begins to release, demarginate. That's the process of what's called demargination. The body begins to demarginate these white blood cells that have been sitting there, to dump them into the circulation to try to help kill the attacking organism to keep the body alive. Okay, well, those white blood cells that are sitting in the wall of the vessel haven't had time to mature. They're the immature one. They're the one we call the band. So that will be when the percentage of those cells are high, that tells you the infection is really even extremely severe. Not just severe, but it's more severe, because you're having a lot of band, and the percentage of band is telling you the individual is really in big trouble. Okay, so you do that. Okay, so now you have, that's basically all you're looking for. I mean, you collect the platelet is important, because in the case of severe infection, it can cause the platelet count to go down. In the case of a chronic infection, it can cause the platelets to go up. Those are technical stuff. I'm not going to bore you with them, but the platelet is important, because you're talking about someone that's probably going to need surgery not too long, and you not to know they have a good platelet level so they can undergo the surgery. Okay, so you do that. Okay, now having done that, now you're going to start doing, well, the red blood cell, obviously I didn't go there, but that's very important as well, to make sure somebody is not anemic versus they're anemic, because they're very anemic. Then you have issue whether they can or cannot get anesthesia to go to surgery. So the red blood cell count is important as well, always important, because without the red blood cell count, you can't carry oxygen, so you can't be healthy. So now we're going to do chemistry profile. What kind of chemistry test are you going to order? Well, you're going to order a complete metabolic profile, which involves liver function test, renal function test, the blood sugar, etc. Okay, now that you've done that, you also want to add a serum amylase and serum lipase. Those are likely to become elevated in acute pancreatitis, regardless of the cause of it. What are you looking for in the chemistry profile? Well, you're looking at what we call liver function test. Namely, is the SGOT elevated? Is the SGPT elevated? Is the alkaline phosphate elevated? Is the bilirubin elevated? Okay, those are the liver function tests. Very, very important. What are we looking for? What's called a renal profile. Because when you do the complete chemistry profile, the renal profile is going to come in. The blood sugar, the BUN, the creatinine, the potassium, chloride, CO2, all these things. Very important, because if the patient is really hemodynamically unstable, he or she may have dropped his or her blood pressure. The kidney is going to sense that. Then these tests are going to become abnormal. The kidney function tests are going to become abnormal. The BUN is because you can't perfuse the kidney very well, so the patient is going to have what's called prerenal isotemia, secondary to lack of perfusion of the kidney, and then this test is going to be abnormal. Okay, so it's very important we look at the whole picture. Okay, now what else are you going to do? Well, you're going to do a prothrombin time. You're also going to do a partial thromboplastin time. Why? Why do you go from there all the way to coagulation? Well, the patient can develop DIC, disseminated intravascular coagulopathy, because of the infection. The very fact that the patient is infected, he or she may have dropped his or her blood pressure. Once you drop the blood pressure, the patient cannot perfuse. The lack of perfusion through this vessel result in secretion of substances that we call procoagulant. Those procoagulant substances can trigger a coagulation setup in the circulation that leads to DIC. That's catastrophic right there. You don't want to get to that point. Because if you get to that point where you have a patient who has DIC, sepsis, and shock, your chances of pulling this patient through is not very good, and you don't want to get there. So you want to really get to the point where the patient presents to the physician early enough that the physician, he or she will be able to do his or her best to try to solve the problem. Don't wait for the last minute. Don't try to ignore the pain and try to self-diagnose yourself. Don't be going to the internet looking up this, looking up that. Those are dangerous habits. Okay. Then these things are done. The next biggest thing that needs to be done is what we call an abdominal ultrasound. Abdominal ultrasound. What are we looking for? When we do an abdominal ultrasound, we were looking at the pancreas. This is the pancreas right here. You could see if the pancreas is swollen on the ultrasound. You could also see the gallbladder, if there's stone in it. So the abdominal ultrasound will evaluate these things for you. It will show you what kind of shape the gallbladder is in. It will also show you if the pancreas is swollen and tender. Very, very important. So it is crucial that one goes about doing all these things in a very thorough way so that you don't wind up losing the patient. Because pancreatitis, if not treated properly or treated too late, can wind up and becoming chronic pancreatitis, which I will be talking about next week, which has its own profile of serious medical problems that I'll be getting into. But right now that you've done all this for this patient, I would have expected that patient, because he or she is so sick, to be in an emergency room setting. The patient would have already gotten some intravenous fluid, and I mentioned to you last week the need to know what type of fluid to give a patient. This patient is very sick, extremely catabolic. He or she is breaking down tissue. He or she needs to be brought into an anabolic setting by giving the patient intravenous fluid that contains glucose. And if the electrolytes are abnormal, you could replace them, put potassium chloride liquid into the bag, the IV bag, to try to replace all these things. If the patient is vomiting, I mentioned vomiting as one of the side effects. Well, the more the patient vomit, the more he or she is likely to have electrolyte imbalance, because electrolyte imbalance, in particular low potassium, is more commonly seen when somebody is vomiting as opposed to when they're having diarrhea, which can also happen in pancreatitis, in particular chronic pancreatitis. So, in other words, God created the body so that we could tolerate the state of acidosis. But however, God did not create the body for us to be able to tolerate the state of alkalosis. And then when you are vomiting, you are pretty much vomiting pure hydrochloric acid in the vomitus. So you're losing a lot of acid. So what's going to happen? You're going to become alkalotic. And once you become alkalotic, what's going to happen to your serum potassium is going to go down, severely down. So that has to be paid close attention to, because the patient give a history. He or she's been vomiting, sometimes for days before he or she shows up to the emergency room. So knowing the electrolyte result of the blood test is very crucial. But you know this patient is going to need electrolyte replacement because he or she tells you he or she has been vomiting for days. And I'm just finished explaining to you, if you didn't know before, that vomiting causes low potassium more commonly than diarrhea. Diarrhea does it, but to a lesser degree. The reason is because the human bowel, the large bowel, as it exists, is alkalotic. The pH of the large bowel is alkalotic. The pH of the stomach is acidosis. So the more acid you lose, the more alkalotic you become. And I'm here to tell you that alkalosis is more dangerous than acidosis. That's just the reality. In particular, because of all the, when your potassium is very low, you're likely to develop cardiac arrhythmias that can be lethal. Your heart can't stop. The same way high potassium can cause the heart to stop, low potassium can cause it to stop as well. Okay. I recently had a patient in the hospital. Potassium was more than 9.0 in the middle of the night. And without any fanfare, I alone, not half a dozen other doctors, I brought that under control in about a day and a half. Had a potassium down to 6, down to 5.6, something like that, in about a day and a half. And I did it alone while I'm sleeping, working with the nurse. They called me all night and we handle it. No big deal, because you know clinical medicine, how to do it. It is an art. It's not a science. It is based on science, but it is an art form based on years of experience and years of accumulating clinical knowledge. It's not a big deal if you know it. If you don't know it, then it is a big deal. Then you look for help. So now that you address these issues, fluid administration is absolutely crucial in pancreatitis, regardless of the cause of it, because the pancreas, once it is swollen, it is secreting massive amount of fluid. That fluid has to be replaced aggressively. But you best replace it with fluid that has sugar in it, because sugar is food. Normal saline is not food. It can raise the blood pressure, but why not do both at the same time? Put sugar in the same normal saline, then you're solving two problems. You're raising the blood pressure, you're rehydrating the patient properly, but you're also feeding the patient by giving sugar. If you need potassium, you add potassium in it. I cannot understand where this normal saline comes about. Every patient who showed up in the emergency, no matter, they could show up with a broken toe, and literally, they got I start an IV, 100% of the time it's going to be normal saline. Why? I have no idea. Where did they learn this stuff from? I have no clue. That's not what I learned. That's not what I'm teaching, because it makes no sense. Okay. Now, there are other things, obviously, that can cause acute pancreatitis, and I'll briefly mention them again, and then I'll tell you about chronic pancreatitis next week. Now, I spoke about gallstone. Abdominal trauma can cause it. Penetrating ulcer. If you have an ulcer, you see where the pancreas sits right here? This is the stomach. So if you have an ulcer in the stomach that's penetrating there, it's that can cause it as well. Then you have a series of drugs, from sulfate drug to tetracycline to azathioprine. All these things can cause acute pancreatitis. In addition to that, you could have acute pancreatitis because of parasite. There's a parasite named Ascaris, very common in the African and in sub-Saharan Africa. So therefore, when somebody has Ascaris, how do you go about diagnosing that? Well, you check the stool for parasite, and you also do a blood count. The blood count, you did the differential. The differential count is going to have elevated eosinophil. Why? Because the parasite is a foreign material, foreign organism. It doesn't belong in the body. So the body is going to react against it. Therefore, you have an allergic reaction, as it were, and your eosinophil is going to be up. So that's why you do the blood count for that, in addition to anemia, blah, 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 blah. Okay, and there's also Chinese fluke. That's right. Chinese fluke can block the circulation here, causing the same backup that I just mentioned, resulting in pancreatitis. You go about that again. Do your blood count, do a stool for ovarian parasite, and then you're likely to find parasitic stuff there. Your eosinophil level is likely to be up, and then you go around to find out other ways, and you could diagnose this parasite, which can also block the tubes here leading to pancreatitis. And of course, as I said, MAPS can cause it, viral hepatitis can cause it, mycoplasma pneumonia can cause it. People who've had radiation therapy to this area can also develop pancreatitis. The list is quite long. Suffice it to say, you had 2 shows on acute pancreatitis, and next week I'll begin to talk about chronic pancreatitis and its associated medical problems. Until such time, keep watching the show. It's Dr. Alcena saying so long and bye-bye.